Okay, I think we are good to start in the interest of time. So good afternoon, everyone, and a very warm welcome from Cape Town on this unusually grey Friday afternoon over here. And thank you very much for joining us on a Friday afternoon. It's wonderful to see you all. I'm Nisha Jacob. I'm a public health medicine specialist at the University of Cape Town. And part of my work is with MeSH, the Measurement and Surveillance of HIV Epidemic Consortium, supported by the Bill and Melinda Gates Foundation. And it's my pleasure to welcome you to the third of a series of MeSH EPI meetings. The aim of these meetings is to spend some time together critically reviewing our HIV data using an epidemiological lens, something we have very limited time to focus on in our busy service-driven work, especially at this time of year in an ongoing COVID pandemic. So at our first session in March, some of you had joined us, and we focused on giving an overview of the HIV epidemic in the Western Cape province. In the second session in July, we explored the role of routine HIV data in pregnancy and vertical transmission. And in our last session for the year today, we are looking at advanced HIV disease. And we have three exciting speakers lined up, followed by a discussion led by three expert discussants with a wealth of experience in HIV epidemiology. And I will introduce each of our speakers and discussants as we go along. But before we start, just a quick reminder to all participants to keep your microphones muted and your cameras off during the presentations. Each presentation will be approximately 15 minutes each, followed by 5 minutes for questions of clarity. And thereafter, we'll have an hour for broader discussion chaired by Professor Marianne Davies. So should you have a question of clarity in the question and answer time, please use the raise hand function or type your question in the chat. And before you speak, please unmute and put your camera on if you're able to. I do recognize that some are not able to. And please do introduce yourself before you ask your question, just so we have a bit of background as well. So without any further delays, I think we can start off with our first speaker. So please join me in welcoming Professor Nilesh Govender, who is a center head at the National Institute for Communicable Diseases and professor in the School of Pathology at Wits University, an honorary professor at the University of Cape Town and University of Exeter. He has worked on cryptococcal disease and advanced HIV disease from a public health perspective since 2007. Thank you very much for joining us, Nilesh. Over to you.
Thanks very much, Nisha. Thank you for the opportunity to present today, and it's great to be able to discuss advanced HIV disease from an EPI perspective. I'm going to focus on HIV-associated cryptococcal disease, and my topic is using routine data to drive public health action in South Africa. I have research grants, but no other conflicts of interest. So I'm going to start just by giving you some background about cryptococcosis. So like other HIV-associated opportunistic infections, cryptococcus or cryptococcosis, which is caused by a fungus called Cryptococcus neoformans and sometimes Cryptococcus gattii, can be diagnosed at various stages as it progresses from localized pulmonary disease through to a period where there's circulating cryptococcal antigen in the blood with or without symptoms. And this is a precursor condition known as antigenemia. And then finally, central nervous system disease, which is initially subclinical and then can progress to fulminant meningoencephalitis with a very high mortality. Based on 2014 data, we previously looked at the global annual burden of cryptococcal disease and estimated that there were more than 220,000 incident cases of cryptomeningitis and over 180,000 deaths. Approximately 3/4 of these cases and deaths occur in sub-Saharan Africa, and cryptomeningitis was responsible for around 15% of AIDS deaths following only tuberculosis. We recently re-looked at the global burden of cryptomeningitis using 2020 data, and these are unpublished estimates. While the absolute annual number of new cases has now decreased to 120,000 cases, cryptomeningitis still accounts for about 16% of AIDS deaths. So we've used laboratory-based surveillance to estimate the burden of cryptomeningitis in South Africa. And we use a program which we call GERMS. This is a surveillance system which is national and uses a network of approximately 200 diagnostic pathology laboratories across the country. The case definition is a laboratory case definition and includes people who are diagnosed with cryptococcal disease using various tests in the laboratory, an India Ink test, a cryptoantigen test, or culture. And we use a 30-day period to define a single episode of cryptococcal disease. So I just want to quickly show you the incidence of cryptococcosis over an 11-year period between 2005 and 2015. These cases exclude blood cryptoantigen positive cases, so they exclude the cryptoantigenemia cases. So our national surveillance began in 2005. The incidence had probably been climbing before 2006. The incidence peaked in 2006, and since then there's been a slow and gradual decline, probably associated with ART expansion. And most cryptomeningitis cases we see are now ART experienced, in ART experienced people. So we've also been using our national surveillance, or a component of our national surveillance, to monitor meningitis outcomes. And I just want to, for those of you not so familiar with cryptomeningitis and treatment, that mention that large multi-center clinical trials of meningitis conducted across the African continent have now refined induction treatment regimens. So now these are much shorter, simpler, and very effective, particularly at reducing mortality. So undiagnosed, we know that cryptomeningitis is always fatal. If you treat with fluconazole monotherapy, and of course if you diagnose the case, survival improves marginally. If you defer antiretroviral treatment to the appropriate time and also manage raised intracranial pressure, that improves survival further. Adding flucytosine to an induction regimen improves survival even more. And if you use the WHO standard of amphotericin B and flucytosine, that improves survival to around 70%. Using a liposomal amphotericin B induction regimen has recently been shown to be non-inferior to the WHO standard and is less toxic. So there essentially are 4 critical antifungal agents required for treatment of cryptomeningitis. And these are obviously needed to achieve 0 deaths. So fluconazole is really the workhorse antifungal. 5-FC or flucytosine is essential for induction treatment or the initial treatment. Conventional amphotericin B is the backbone of the WHO standard, and liposomal amphotericin B is the backbone of the Ambition trial regimen, the newly released trial. I just want to quickly give you some details around an access program for flucytosine. Flucytosine is not registered in South Africa, and to catalyze access, a national program was set up for cryptomeningitis in 2018, and we used routine surveillance to monitor the outcomes. And I just want to focus down on the 1,500 patients who received antifungal treatment, 40% who received 5-FC or flucytosine-based regimens versus the remainder who received other regimens. Just the headline findings: the crude in-hospital case fatality ratio based on our surveillance data, 24% for people being treated with flucytosine induction treatment, and 37% for other regimens. And once we adjusted for relevant confounders, treatment with a flucytosine-containing regimen was associated with a 53% reduction in mortality. So we've been monitoring the in-hospital case fatality ratio for cryptomeningitis in the same way over a very long period of time since our national surveillance began. This occurs only at sentinel hospitals where we have a team of surveillance officers who collect outcome data from patients with crypto disease. And what you can see from this graph is that the in-hospital case fatality ratios remained high and very stable. So fluconazole has been available since the early 2000s through the Diflucan Partnership Program initially, but fluconazole is now widely available in various generic formulations. Amphotericin B became available in around 2005, and access gradually increased, and currently more than 90% of people receive amphotericin B-based regimens if they're diagnosed with cryptomeningitis. I've just shown you that based on a recent access program in 2018, or based on those data, we've shown a reduction in mortality. That's not shown on the data from the national surveillance program, probably because insufficient patients have received treatment with flucytosine to date. And then, of course, more recently, the Ambition trial results have been released, and it's possible, of course, that guidelines may change in future. So what else is needed to reduce cryptomeningitis deaths? It's clear that treatment is insufficient. But just quite quickly talk about a screen and treat intervention for crypto disease, which was implemented globally. The WHO recommended cryptoantigen screening as a key part of the package of care for people with advanced HIV disease. And a large clinical trial from a few years ago demonstrated around 30% reduction in mortality. And so since then, country-level screening programs have been set up globally to diagnose these cases of antigenemia. So essentially how crypto screening works, cryptoantigen, which is a component of the fungal capsule, can be found in the bloodstream weeks before symptoms of meningitis develop. And so people with advanced HIV disease are screened for cryptoantigenemia. Those who screen positive are then tested for meningitis by lumbar puncture and prescribed appropriate antifungals either for meningitis or for antigenemia. And that's essentially how the screening program is designed to break the connection between early crypto disease and meningitis. And so the focus, of course, then is to detect people without symptoms, people with antigenemia who may or may not have subclinical meningitis. Just to point that in places where diagnostics for cryptomeningitis are not widely available, screening can also flag people with symptomatic meningitis. I just want to give you some quick data on monitoring cryptoantigen screening in South Africa using routine data. So South Africa's National Reflex Laboratory Screening Program has been a major success in many ways. More than 1 million people with a CD4 count less than 100 have been reflexively screened in public hospitals and primary healthcare clinics since the inception of the screening program in 2017. And more than 64,000 people with cryptoantigenemia have been identified. You can just see from this graph here, I'm showing the cases of meningitis, and these are numbers of cases. And so you can see in gray, since the peak, the incidence peak was in 2006, but you can see the numbers of cases have steadily declined. But what you can see is since 2017, based on crypto screening, we've detected many more cases of crypto antigenemia in addition to patients with meningitis. So we've also looked at crypto antigen prevalence among people with a CD4 count less than 100, and we've shown district level hotspots where resources could potentially be allocated to firstly ensure that people with advanced HIV disease access HIV care earlier, and also to ensure that people who test positive for crypto antigen are managed appropriately. Gauteng province and KZN province contribute to more than half of the cryptoantigenemia cases. This may reflect the burden of advanced HIV disease in these two provinces. And KZN has the highest CRAG prevalence, almost 40% higher than the national average, And this may be related to a low median CD4 count at the time of CRAG screening, but also to other ecological factors. I just want to quickly take you through a recent time series analysis that we've done. Greg Green, who works in my team and is doing, he did this as part of his PhD work, looked at a time series analysis of national CRAG screening data. And these graphs essentially show you the weekly number of CRAG tests over time between 2017 and 2021. What you can see is a gradual decline in the weekly number of CRAG screening tests at both hospitals and clinics, from around 7,000 to around 5,000. So these are screening tests among people with a CD4 count less than 100. And so this reflects a similar decline in the number of samples with a CD4 count less than 100. This was an interrupted time series analysis looking at the effect of COVID restrictions in the early 2020. And so what you can see here is that CRAG testing dropped substantially in clinics, but not in hospitals, and is continuing to decline in clinics, but increasing in hospitals. Now, when we look at the trends in positive blood CRAG tests over the same time period, we're also seeing a gradual but less decline in the weekly positive CRAG tests. So these are people with cryptoantigenemia. When we look at the effect of COVID restrictions, the antigenemia cases dropped significantly in clinics, but not in hospitals, and it's continuing to decline both in clinics and in hospitals. As you'd expect with the changes to the numerator and denominator, the proportion test positive increased between 2017 and 2020 from about 5% to about 6%, or more than 6%. And then what we saw after lockdown was an increase in proportion CRAG positive, and then a decreasing trend since then, probably related to some normalizing effect. Just to point out that on average, the new cryptomeningitis cases have gradually been declining over the same time period. It's probably a counterbalancing of increased ART access causing a decline in cryptomeningitis, but also increased case finding through the crypto screening program. And there's been no significant change with COVID restrictions. Just in terms of evaluating CRAG screening, I want to point out some work that we did very early on when we were still deciding how to deliver CRAG screening across the country. At that time, we evaluated a provider-initiated screening program in the Western Cape and found that only around a quarter of eligible people were actually screened if left up to the providers. And so this gave impetus to a national laboratory reflex screening program. But even though we've got this national reflex laboratory screening program, in reality, the potential, I don't think, is necessarily being realized. And some of the reasons for this are highlighted on the slide. For instance, people with a positive CRAG test, as you know, should start fluconazole, but only about half of people receive appropriate treatment, usually because they don't return to the clinic after being screened. And we know this because we've been conducting a study called CASTNet. This is a retrospective cohort study conducted in 27 sub-districts, and we've included 3,000 CRAG positive patients diagnosed between 2017 and 2019, looking at their management and their outcome 6 months. And essentially, we're imaging their charts in the clinics and abstracting the data onto standardized case report forms. Just to point out that the chart abstraction is now fully completed thanks to our team, and data cleaning and analysis is now underway, so we should have the results fairly soon. So one way to break the connection between cryptomeningitis and deaths is better treatment. As I've just shown you, another way to do that is, of course, cryptoantigen screening, so that people with antigenemia never develop cryptomeningitis and then don't die as a consequence. But of course, if you don't start treatment on those who are identified, as being CRAG positive, then the screening program just won't work. Of course, you also have people who interrupt ART or who have ART failure, and those patients may also develop meningitis, as may those who don't know their ART status. Even though CRAG screening may not be working as well in practice as it could to reduce mortality, people who don't know their HIV status or in whom ART is failing may be also bypassing CRAG screening and present to care with symptomatic meningitis. We're also not screening everyone with a CD4 count less than 200. Nisha, I'm aware that I don't have a lot of time, so I'm going to just briefly end by just talking about should the CD4 threshold for CRAG screening be increased to less than 200. And the WHO currently recommends this. This is recommended by the Clinician Society, but the National Department of Health has not changed its guideline as yet. We conducted a survey last year and essentially found that, as you'd expect, we tested all patients across the country with a CD4 count less than 200 over a month-long period, and essentially found that the prevalence of anticoagulia dropped as the CD4 category increased. If we were to screen people with a CD4 count between 100 and 200, case detection would increase by about a third. Just interestingly, it would increase, there would be better case finding more on primary care facilities versus hospitals. So routine data has definitely driven action in various ways that I've outlined. And I just want to end by saying, could we end cryptomeningitis deaths in South Africa or perhaps in a place like the Western Cape? Given that many of the essential tools to reduce deaths are already widely available in a province like the Western Cape. So I'm going to leave this slide up and just acknowledge my team, our funders, and the GERMS network. Thanks very much. And sorry I went over time.
Thank you very much, Nilesh. That was a really clear and insightful presentation. Wonderful thoughts that I shared. I really like the slide that you've kept up here. I think we have time for one quick question of clarity, if anyone has. I don't see any questions in the chat. Does anybody have any questions now, or we can otherwise take it for broader discussion in the second hour of today's session? Graham, I see you have a question. Go for it.
Yeah, thanks very much, Nilesh, for that overview. Just quickly, you went over it quite rapidly. I just missed it. In the COVID period, is the proportion of people with a positive CRAG increasing, did you say?
Yes. So, I'm sorry, you meant in the COVID period. So
yeah.
We've seen a drop in the number of positives, but only at clinics. In hospitals, it sort of continued that decline that we were seeing before.
But so that's the number. What about the proportion?
Oh, the proportion. Here you can see the proportion, Graham. I think it's just normalizing. It was steadily increasing, and I think that after COVID, we see it sort of increasing, but then probably gradually declining to what it was prior to COVID. I think it's probably normalizing, but I'd be interested in your insights.
Okay. Okay, I see the increase is immediately after the dotted line, and then it does decline. Yeah. Okay. No, thanks. I just missed that. Thanks.
Perfect. Thank you very much, Nilesh. That was really fantastic. And I'm sure you've given us a lot to think about for the broader discussion in the second hour. So I'd like to now welcome our next speaker, and that is Mariette Smith. Mariette is a senior data analyst at the Provincial Health Data Centre at the Western Cape Department of Health. Mariette did mention that she's having a few connectivity issues, so Mariette won't be switching her camera on. But over to you, Mariette. Feel free to share your screen. Great, we can see it. Thanks, Mariette. Over to you.
Great. Am I also unmuted? I seem to have
Yes.
lost my screen.
We can hear
great.
you. Perfect.
Awesome. Thank you very much for the introduction and also the opportunity to present today. I'm just going to give a quick overview on how consolidated routine health data can be used to monitor markers of advanced disease. I'm not going to go into too much detail. But we're going to look at CD4 counts as an indicator of severe disease. Cryptococcal disease has been covered very well by MeSH, but I can also show some trends in the Western Cape. TB and HIV comorbidity as an indicator of the severe disease we can look at. And then also the contribution of advanced HIV disease to COVID-19 deaths. So I'm sure most of you are familiar with the Western Cape Data Center and how data from various sources are integrated and processed on a daily basis, and then transformed into systems that can be used for clinical support, reporting purposes, and also for clinical care. In a previous meeting, Alexa had shown quite extensively how this data can be used in very particular ways to develop disease cascades and disease episodes. So I'm not going to go into that, but the information is available if you are interested. So the first trend to look at is CD4 test results. This graph shows that while the number of tests has decreased since 2014, the number of low CD4 results has remained constant in the bottom line and is still a cause for concern. Looking at cryptococcal disease, in the orange line, we can see that the disease trend has remained fairly constant, although we can see the effects of the increased screening. Yeah, the two metrics from a previous slide. This time I've just overlaid the low CD4 counts for these crag positive people, and then also fluconazole treatment for the serum positive screened. So we can only report actually on the treatments we receive electronically, but it seems to track reasonably well with the serum positivity. So since flucytosine has been introduced around about 2018, 2019, the numbers are fairly small, but roughly calculated, it seems that it does make a difference in decreasing deaths within the first 6 months. So this year, just from the guidelines, amphotericin B plus flucytosine, and we can see that the uptake in use is ongoing. So we know that the Western Cape has a high TB burden, and we've recently launched a public-facing TB dashboard similar to the COVID dashboard, with the hope of raising public awareness and advocacy. So this is available online. If anybody's interested, you can just search on the website of the Provincial Health Department and you will find it there. We hope to add some more details here about deaths and comorbidities, but at the moment it is not there yet. So looking at TB deaths and HIV co-infection, you can still see that most of the deaths are associated with HIV infection and also with very low CD4 counts. So here's the trend for the HIV positive patients or TB patients, and here the trend for HIV negatives. You can also see that we had a bit of a dip in death data in 2014, it's not because the deaths decreased, but because we lost access to some of the most important mortality data that we use. But the trend still remains. We also know that about a third of new TB diagnoses are in HIV positive people. About a quarter, yeah, or 30%. And then for those whose HIV status is unknown before TB, we can diagnose a further 13 to 10% of HIV cases after the TB episode started. This shows that the TB program does a great job at testing. And I think they also take great pride in this work. So many of you would also have seen this research into COVID mortality done by Prof. Mary Ann Davies and team. And this work highlighted the increased risk of death when co-infected with HIV. But after this paper was published, she did a further analysis and found that for the HIV infected people who are well, there's the risk of dying is 2 times. But when not well, so where viral load is increased and CD4 decreased, there's almost the risk is almost 4 times as high as the reference group. So nearly a 4-fold increase in deaths with high viral load and low CD4s. And I'm hoping she will be able to say a bit more about that. So special thanks as always to all my colleagues and the data center team and all the other teams that support our work at the data center. Thank you.
Fantastic. Thank you very much, Mariette, for a great presentation and overview from the Provincial Health Data Center. Are there any questions of clarity for Meg? I don't see anything in the chat, but please feel free to raise your hand if there are any questions of clarity before we move on to our third speaker.
Nisha, I just have a quick question for Mariette. I wanted to ask about capturing antifungal treatment data in the Provincial Data Center. You know, outcomes and antifungal treatment, how exactly is that captured? Thanks.
Yes, so we are planning to look more deeply into that. From what I've seen so far is that not all the treatments are actually captured electronically, but it's captured fairly well for say amphotericin B and flucytosine. Not so much for fluconazole, but I can't give you actual numbers, but we can definitely look into that.
Great. Thanks very much, Mariette. Any other questions of clarity for Mariette? Or further comments? Okay, it doesn't look like anybody has any questions. So Mariette, that means you were quite clear in your presentation, and we just want to thank you again for that presentation and for all the work that everyone in the PHDC team has put together for today's presentation. So thank you for that. So let me welcome our third speaker, Dr. Meg Osler. Meg is a Senior Technical Advisor for Strategic Information for the University of Cape Town and the MeSH Consortium. Meg stewards the development of the Tier.net health information system being used in multiple countries in Africa. And in addition to that, Meg continues her work as a PhD candidate, considering the impact of policies on morbidity and mortality within the HIV services. Meg's interests lie in improving health information ecosystems and using the resulting population level data to improve patient management and service delivery. Thank you for joining us, Meg, and over to you. We can see you. I know you had a few technical challenges, but we can see you.
Fantastic. Thank you so much for inviting me to speak today. I'm just going to try to share my screen.
We can see your screen, Meg. It just needs to be in presenter mode.
Fantastic. How is
Perfect.
that looking?
Perfect. Thanks,
okay,
Meg.
Great. Thanks so much. Okay, so I'm taking a closer look at specific predictors of HIV disease, advanced HIV disease. And as Mariette and Lesh have pointed out in their presentations on cryptococcal meningitis and CD, the number of people dying with advanced HIV disease, it does not seem to be subsiding, and it has stayed at similar proportions over the last many years. In 2018, we published a paper that looked at the proportion of patients with a CD4 count less than 50 and looked at their engagement in care. And we found that the majority of people from 2015 onwards that had a CD4 count less than 50 was actually coming from the cohort of people that had already started ART. So this prompted us to take a closer look at people on ART to try to understand why there's such a large number of people with low CD4 counts. And it was easy to notice that many of the people in the ART cohort were being tagged as lost to follow-up, but then at a later point in time were coming back into care. So we decided to try to better quantify these events and have taken a special focused look at interruptions. So interruptions are an important driver of increases in viral load count, HIV transmission, morbidity, mortality, and ART drug resistance. Yet most of the studies that you can find in the literature report a cross-sectional average estimation of people lost to follow-up. And knowledge of the frequency and the patterns of interruptions and associations with mortality are important in designing interventions to retain people in care. So we were hoping to do just that with this study. So we performed a quick analysis on all people on ART who had a CD4 less than 100 and their status at the time of their CD4 less than 100, which can be seen in the left pie. 70% had interruption, at least one interruption that was greater than 6 months. 5% of those with the CD4 less than 100 were new to ART, and then another 25% had never interrupted. And of those people that were on ART, their most recent viral load was looked at, and 80% had no viral load or a viral load that was greater than 1,000 copies per mil. We then looked at those same people with a CD4 count less than 100 in the pie on the right to look at their current status and found that 27% of those people had died. And that's in comparison to 8% in the same cohort of people of all people on ART in the cohort of the study. 47.5% are still in care, and 25% had a gap that was larger than 6 months in their status at June 2020. So we designed a study to look at the patterns and impact of interruptions on mortality. So the main exposure was interruptions in people on ART care, and the main outcome was mortality. We used a flexible parametric survival analysis design, particularly the Rosen-Palmer parametric survival analysis. And we included people on ART in the Western Cape public sector with interruptions being measured as time between visits at the healthcare facility. We looked at both 3-month gaps and 6-month gaps, and we also looked at the differences stratified by sex. The majority of the people in the ART program during this time period received 2 months of ARV drugs, but more recently, people were receiving 4 months of drugs during the December holidays. So there is some noise in the 3-month gaps. So we decided that we would rather have our main focus as 6 months, but we still did a sensitivity analysis on the 3-month gap. All of the data was linked by the PHDC, and that includes clinical assessment data, labs, pharmacy, and death registry data. And we did receive ethical approval to perform this study by the University of Cape Town Ethics Board. So just to see who was included or excluded from the study, we had to, in order to be able to link the study participants to mortality or the death registry, we were required to have a South African ID. So there were 284,858 people with a South African ID during this time period. We had to kick out about 20,000 of them based on the fact that during the time that we digitized from paper to electronic systems, the easiest and most efficient way was to back capture some people in batches. And that just meant that if they were on ART for a long time before the facility was digitized, we saved their first appointment and then continue that save up until the current appointment. And if we're looking at interruptions, we can't use that data to measure the interruptions or the attendance at the health facilities. So those were kicked out. We also had 3,000 that didn't have a date of birth or a sex recorded in the data sets. So we also had to exclude them. Of the people in the study, 56%, close to 57, sorry, never had an interruption, whereas 43% did have an interruption. I'm just hesitating because I realized this data is all very new and I realized that I actually, okay. So 9% had died in those that never had an interruption, and 8% had died in those that did have an interruption. But what's important to recognize is that those that died having never had an interruption, a large majority of them died within the first 6 months on ART. And those people never had a chance to have the event or interruption take place. But in those that did have an interruption, much smaller amounts died in the first 6 months. So almost 8,000 deaths in those on ART greater than 6 months were in those that never had any 6-month interruption or longer. But over 9,300 deaths in those who did have one or more interruptions. So there's a great amount of interruptions once we look past the 6-month duration on ART. So here are the baseline characteristics. When we looked at 6 months, it was 57% having interruptions and 87% having a 3-month or greater gap. But as I said, that could be noise revolving around the December holidays when some facilities handed out 4 months of drugs at a time. The interrupters appear to be younger and have started ART in earlier years. And we didn't see a big difference in females and males. The females make up 70% of the cohort anyway, and the interrupted also make up 70%. Pregnancy seemed to, there seemed to be a few, sorry about that. There seemed to be a bit higher pregnancy rates in females that did interrupt. So here I'm looking at the heat maps, and the top heat map shows the people who are alive, and the bottom heat map shows people who died during their time on ART. And the colors represent the average interruptions for a 6-month gap. And as you can see, the x-axis is time since initiating art in years. And as the duration on art increases, you can see there is a definite increase on the average number of interruptions. You can also see that those that have died have slightly more interruptions than those that are alive. We don't see a gradient of interruptions decreasing or increasing as the art program matures in these particular heat maps. Although the interruption patterns are similar between male and female, there's a slight decrease in male interruptions as the number of interruptions increase. So males make up about 30% of the interruptions of one interruption, but then drop down to about 26% of the people who have 5 interruptions. The death rate proportionally is double in males, though, especially in those having 1 to 5 interruptions. So during exploration of the variables, we found that the Schoenfeld residual tables and plots illustrated that the interruption variable violates the proportional hazards model. In other words, the hazard ratio is not constant over time. And that is why we decided to use the flexible parametric survival regression. And the interruptions variable was modeled as a time varying covariate. So this is the results of the multivariable table. In the first column, you can see the univariate results. In the second column, you can see the main results at 6 months. And then to the columns to the right of the gray line show the results of a model looking at 3-month gaps, and then the results stratified by male and female. So the predictors of mortality include older age, earlier years initiating art, low CD4 counts, interruptions, and TB prior to art start and at art start. You can also see in females that pregnancy is protective. We've reported the hazard ratio for interruptions at 5 years to allow for at least 4 interruptions to take place. If we reported the results from the model, you would see a decreasing trend, and that is because it's averaging the interruptions over time, but yet interruptions haven't had time to take place, and that's why we had to show a later time period. So these are the visualizations of that same output model. So the top row shows cause-specific mortality rate per 1,000 person years. And the bottom row shows the hazard ratio. The first column shows the full model, and then the next two columns show the stratification between male and female. In the top row, you can see the 0 interruptions has a high beginning mortality rate, and that is due to the mortality that we see in the first 3 months of art. And then you can see that with each increase in interruption, there is an increase in hazard for mortality. In the bottom row with the hazard ratio, you can see that a person who has 4 interruptions has 3 times the hazard in comparison to a person that doesn't have any interruptions. So the study on interruption showed that time-varying confounding of some predictors on outcomes. And because of this time-varying confounding, we had to consider a causal impact of treatment averting mortality. We needed to use either a regression discontinuity design or a marginal structural model design. So we decided to look at a regressional discontinuity to look at the eligibility criteria for art. And regression discontinuity designs can mimic randomized control trials, as the regression discontinuity looks at predictors for an outcome very close to a specific threshold. And people on either side of that threshold are thought to be similar in clinical presentation as well as characteristics, and that the instrument measuring that threshold, and for our study, that measurement is a CD4 count, is highly variable. So those eligible and ineligible very close to the threshold are considered to be randomized by that instrument or by the CD4 count. So the next few slides I'm going to show you are outputs of the regression discontinuity model. And just to orient you, I'm going to use this first slide. The x-axis shows the CD4 count at baseline of ART. And the red vertical line that you see in this model is showing the threshold for the time period. This time period, as you can see above, is for the 200 cells, which happens to be between January 1st, 2007 and the 31st of August, 2011. The gray bars are the ones that show people who get onto ART within 6 months. And then the outlined bars show people who didn't get onto ART within 6 months. So you can see that there's a higher level of people getting onto ART that are eligible for ART, or those that are on the left side of that red vertical line. But that many people on the right side of the vertical red line who are considered ineligible because of the CD4 count have also been put onto treatment. And this bottom row just shows the proportion of ART uptake. So on the left-hand side are people that are eligible, as opposed to on the right-hand side of the red vertical line, people that were considered ineligible based on CD4 count. And the risk difference being 9 in the 200 cell period. So as you can see on the right-hand side, as you get closer to the threshold, there are a lot more people that are considered ineligible but are getting onto ART, and these are probably based on clinical symptoms and sickness. And these just, the y-axis shows the proportion. Here I'm just showing the discontinuity of people who start ART and of those that don't start ART. And then the risk difference is labeled at the top. So the first column here shows the time period for 200 eligibility criteria of 200 to get onto ART, the middle for 350, and on the right-hand side, 500. And I think here you can show that, you can see that there's quite a big discontinuity in the mortality of compliers. These are people who were eligible that started ART and people who were not eligible that did not start ART that are being showed in this bottom row. And you can see that people who were close to the threshold but didn't start ART with a 200 CD4 cell count had the same mortality of people that had less than a CD4 of 100 that were able to start ART. And the case is the causal average complier effect, which is quite big here in the 200 cell eligibility criteria time period, and the intention to treat risk difference. But as you look at 350 and 500, we don't see as big a benefit. So in summary, both studies confirm the importance of starting people with low CD4 counts, whether that's a baseline CD4 count or people who have interrupted and need to restart ART. And the retention on treatment follows cyclic patterns of engagement and interruptions for 57% of the cohort on ART. The interruptions were associated with increased risk of mortality and highlights the need to treat people who interrupt as a high-risk group. The risk difference estimations in the regression discontinuity are very striking at low CD4 counts, but only modest as we look at the higher CD4 counts. And this is mainly due to the lower event rates overall. really shows the opportunities that we have when we have a consolidated longitudinal data that looks at a population level to consider effectiveness of guidelines. And just wanted to point out the WHO guidelines on tracing re-engagement in care, as we need to consider interventions, take up these recommendations for interventions that will limit this cyclic engagement and disengagement from care. I want to thank the UCT CIDR and MeSH teams, the Western Cape government, and all the clinical data and information staff members that are working so hard on the ground. Thanks so much, Nisha.
Thank you very much, Meg. Getting some virtual applause there. Thanks very much for a fantastic presentation, Meg. And I think it was a really good expansion from Mariette's presentation and really gave us a deep dive into interruption patterns of people on antiretroviral therapy. So thanks for that. And thank you to all three presenters. Those are fantastic presentations and very well timed to lead us into our broader discussion. Before we kick off the discussion, are there any questions of clarity from Meg's presentation? I see Brian has posted a very interesting comment and question around CD4 counts, which I think will be quite useful to delve into during the discussion period. Any questions of clarity based on what Meg has presented? Okay, I see Graham, go for it.
Thanks, Meg, for a great presentation. Just a point of clarity, the 57% that you mentioned in terms of patients who interrupt ART, is that using the 6 month definition?
Yes, the 57% is using the 6 month definition.
And what was the median follow-up of that cohort?
I believe it was 6 years, but I can quickly look.
Okay. Yeah, just a ballpark figure. So it's around 57% over 6 years. Yeah. Okay. Thanks.
Thanks, Graham. Marianne, go for it.
Thanks to Meg and all the presenters for excellent presentations. Meg, just to ask, in your last analysis, the regression discontinuity, when you looked at differences in mortality for the different CD4 values, also what was the duration of follow-up there? Because obviously in the short term, you wouldn't necessarily expect an impact for 350 and 500, but those impacts we expect could potentially only be at much longer durations.
Thanks so much, Marianne. I can't believe I forgot to mention that. We were looking at...
You may have mentioned it and I missed it. So.
No, I think I forgot to mention it. My apologies. We were looking at impact at 24 months. And just to clarify Graham's previous question, the median follow-up for interrupters was 4 years, whereas non-interrupters was 6 years.
Great. Thank you very much, Meg. And Marianne, while you're on, I think it's a good time to actually lead us onto our broader discussion. And I'd like to formally welcome and introduce you, though I think you need no introduction here. But I'd like to welcome Professor Marianne Davies, who will chair the discussion over the next hour. Marianne is a public health medicine specialist in the Western Cape Department of Health, responsible for epidemiology and surveillance, and the director of CIDR, the Center for Infectious Diseases Epidemiology and Research at the University of Cape Town. Marianne has led several HIV cohort research projects, and we've already heard a bit about some of Marianne's research today. And has addressed various policy and implementation questions through her research. And since March 2020, Marianne has played a key role in epidemiology and surveillance of COVID-19 in the Western Cape province. Marianne will be joined in the discussion by two renowned colleagues in the field of HIV who also likely need no introduction. So Dr. Nathan Ford will join us. He is a scientist with the Department of HIV, AIDS and Global Hepatitis Program of the World Health Organization in Geneva and the head of the WHO Guidelines Review Committee. Nathan has extensive experience supporting HIV programs in a number of countries in Southern Africa and Southeast Asia. and is also an honorary senior lecturer with the Center for Infectious Diseases Epi and Research at UCT. And Dr. Ford will be joined by Professor Graham Meintjes, who is second chair and deputy head of medicine at the University of Cape Town. Graham is an infectious diseases physician who leads an active research program focused on conditions that affect patients with advanced HIV, namely disseminated tuberculosis, cryptococcal meningitis, and the immune reconstitution inflammatory syndrome. So a very warm welcome to Marianne, Nathan, and Graham. It's really an honor to have you join us today, and we really look forward to the discussion today. Marianne, I'm going to hand over to you, and Alexa Heeks and Andrew Bull will assist us in keeping an eye on the chat for any questions or discussion, because we do want to have discussion from the audience as well, and comments and questions. And then Andrew Bull will conclude the discussion just before 4 p.m. So over to you, Marianne.
Thanks very much, Nisha, and it's really a pleasure and an honor to be invited to share this discussion with people who are really so expert in the field of advanced HIV, together with our presenters. So thanks very much, and I really do hope we can have some interactive discussion about this persistent problem of HIV that continues to cause morbidity and mortality in our setting and hasn't gone away. Two things struck me as I was listening to the presentations, and I'll make those comments first, and then I'll go to Nathan because he's put his video on first bravely, and then we'll go to Graham after that. So what struck me, and it was also highlighted in the chat, is firstly this issue of declining measurement of CD4 counts, but also that as we see and link that to this pattern of treatment interruptions, at the moment, our policies are around measuring CD4 at diagnosis and early on in a patient's treatment course, but how much are we measuring CD4 counts when people return to care, if we are trying to get them back into care? And is that something that we should be thinking about doing? And are we missing a group of patients potentially who are very vulnerable? And as Nilesh talked about, expanding the criteria for cryptococcal antigen screening, but should we also be looking for more people with low CD4? So that's one thing for people to think about, and I'm interested to hear what both the panelists and the and others in the group think about that. And then the second thing that struck me is, as we have kind of got the low-hanging fruit in terms of HIV, and we do have this persistent group of patients who are much more vulnerable than I guess the run-of-the-mill people living with HIV, if I can call it that, not that anyone wants to be run-of-the-mill. But that some of the increase in mortality that Meg showed with interruptions, sure, a lot of that is due to interruptions themselves, but could some of that also be due to the fact that these people are just a whole lot more vulnerable in society more generally? These are people who have chaotic lives, who find it difficult to stay in treatment, and who may be vulnerable for a whole range of other reasons. And are there ways that we should be thinking about how do we reach more vulnerable people in our health systems more generally than obviously getting them back into treatment? But is there something more that we should be offering, or is there something more in terms of a whole of society approach for people who are vulnerable? So those are my initial thoughts, and then I think we'll go to Nathan and Graham, and then give the panelists, the speakers, a chance to respond.
I'll go ahead, Marianne. So just a very general statement to begin with, and as I was listening to the presentations and seeing the data being presented, I was reminded that in fact the existence of WHO's global guidelines on the management of advanced HIV disease are in great part thanks to the data that has come out of South Africa and many of the presenters on this call. Just a brief historical anecdote. Back in 2015, the entire global HIV community was focused on getting rid of CD4 for initiation of treatment and moving towards treating all people living with HIV irrespective of CD4 count. And I think that huge momentum led to a rapid decrease in interest in the role of CD4 counter tool, and a belief as well that the solution to all of our problems was just to get more people on ART as quickly as possible. And it's the data from South Africa that contributed to the realization that our problems have not gone away. There is a persistence. It came from the cryptococcal disease data from the Western Cape. It came from the IDEA data sets of CD4 at start of treatment. And it was really those two bits of data that led WHO to be motivated to draw attention to the fact that while we must strive to put as many people on as possible on treatment as early as possible, we cannot lose focus on the persistent burden of advanced HIV disease. So it's very much thanks to your work that we started off with this guideline, and thanks to the reality trial, we became aware that there can be a public health response to advanced HIV disease. So I just wanted to start by acknowledging that, and perhaps I will add relatedly, in responding to one of the comments that was raised around the important continued role of CD4. I personally have run out of ways to say that CD4 is still important. The WHO guidelines have never said otherwise, and in fact also make a statement on the importance of CD4 at return to care. So those recommendations exist, but unfortunately for political and financial reasons, there has been a disengagement from CD4 testing. That has been reversed in recent years with PEPFAR, for example, in reinstating conditions under which countries can ask for funding for CD4 cell counts. So there is a slight reversal, but nevertheless, many countries have lost capacity to undertake CD4 testing, and it's been, you've showed the pattern in South Africa. It's much worse in many other countries, and we're continuing to fight back and pass the message that without CD4, we are really doing a very approximate job of understanding who needs interventions in order to reduce mortality. I'll stop there, but I have some other comments I'd like to make, but I'll stop now and I'll come back later. Thank you.
Thanks very much, Nathan. Certainly, we are very grateful to you for continuing to beat the drum around CD4 counts. Graham, can we go to you? There are also a number of questions in the chat or comments in the chat, which is great, but I think let's go to Graham, and then we'll try to look through the chat and go back to our speakers.
Thanks, Marianne, and thanks for the invitation to participate this afternoon. I think from all three speakers, we had a really great epidemiological overviews of the issue and kind of a kind of rigorous epidemiological approach applied to the issue. I want to come in from the perspective of a clinician, working often with looking after these patients at the hospital level and provide some what I think are insights from the clinical side to kind of give a clinical feel to the problem, and then elaborate a bit further on the issues from a patient perspective that you alluded to, Marianne. Now, if one just looks at this from, take the viewpoint of Khayelitsha, there is, if one takes a step back and thinks about it, there are about 12 public sector clinics in Khayelitsha providing antiretroviral therapy, no cost associated. All of them, with everybody there's probably a clinic within walking distance. And, ARVs for everyone has been offered for several years now. And yet, despite that, we have this situation where we still see large numbers of people developing advanced HIV. And I think, that the solution to the problem is really grappling with the issue of why there's disengagement from our healthcare services, and why we are not managing to keep people in care and reach them when they disengage from care, and really looking at it from a patient's perspective, both in terms of the experience of the health services, but also, as you say, from their lived experiences in those communities and what's contributing to them stopping treatment. So what tends to happen is, currently most people who are diagnosed with HIV, and there are, extensive testing services within the community, will get onto ART quite rapidly. And then there's the interruptions that Meg has spoken about. There's also, partial adherence of patients who are attending care and obviously then poor immune reconstitution. There's failures on therapy that people aren't appropriately switched to second-line therapy, and poor tolerance of therapies, and for many reasons people are not getting adequate immune reconstitution despite the theoretical possibility of achieving that. And then people are remaining immunosuppressed in the community, and then being admitted to hospital with conditions like cryptococcal meningitis. But by far the number one reason for admission to hospital in the community is with disseminated TB in the context of advanced HIV. And that's the number one cause of admission, and the number one cause of death in these patients. Bacterial infections as well, pneumocystis, pneumonia, and then renal disease and neurological disease as a complication of advanced HIV. And the majority of these deaths actually occur in hospital. And so patients get so sick, they're brought into hospital and die, during that hospitalization or shortly after that hospitalization. And, I think the central problem for me is one of, that we haven't grappled with enough, which is how do we ensure that we make antiretroviral therapy as convenient as possible for people, the services as accommodating for people's disrupted lives, allowing for interruptions to occur and people to return, and really taking ARVs out into the community and in the messaging and in the access to care more effectively than what we do. And I think that, there's some huge opportunities that we can capitalize on that in terms of improvements in care. The availability of dolutegravir regimens with a much higher barrier to resistance, and with better tolerability than, for instance, PIs. And that even if patients are interrupting, they're much less likely to develop resistance than with the NNRTIs. That's one. And then the whole issue around injectable ARVs and where those fit going forward. But those are kind of almost biomedical interventions, but we've really got to think about the social aspects, the lives that people are living, the other challenges that they have in terms of, disrupted family circumstances, psychological stresses, the dangerous lives that they live, substances, etc., and how we, address the need for ARV retention within the context of those things. So to me, that the solution comes from health systems research. And while I do see the value of doing more CD4 testing, I think that's almost, to me, it will have an impact. But it's a minor component of the issue. The issue is a health services one, and also just being more public about this issue about retention on ARVs. There's not enough messaging in our communities and in our media about the need for adherence and coming back to care if you interrupt. It's really just something that we assume people know, but we should be broadcasting it more. And yeah, so those are some initial thoughts from a clinician's perspective, and really urging that we see this as more than just a biomedical solution by implementing different strategies in the clinic.
Thanks, Graham, and certainly concur that the CD4s will help us, but that the bigger challenges around making it easier for people to stay on treatment, remain a key to this issue. And I was just struck this morning. I was driving around and everywhere I looked, I saw a poster telling me that I needed to get vaccinated, which is great because we need those at the moment. But we don't have a poster everywhere I look telling me that if I'm on some sort of chronic medication, it's really important for me to take my treatment and stay in care. So, yeah. There's been quite a bit of discussion in the chat around the difference in the Western Cape data in terms of flu cytosine access and compared to the national data, and the mortality decline that we saw in the Western Cape compared to in the national data. And I'd like to bring Nilesh in just to respond to that question because he has some interesting comments there. But Nilesh, just before we go there, Graham, you were obviously involved in the Ambition trial. And I just wondered where we are in terms of, and I'm now going to forget the name of the new drug, but, and you know, whether that is going to be moving into clinical guidelines at some point.
Yeah, so just the Ambition trial evaluated what is now WHO standard of care, which is 1 week of amphotericin B plus flucytosine, compared to a novel regimen, which is a single dose of liposomal amphotericin, or otherwise known as Ambizome, a single dose with a backbone of fluconazole and flucytosine. And what it demonstrated was that was non-inferior. So there's no survival advantage from the new strategy. It's just non-inferior and with less toxicities. The publication is under review, and once it's been published, I think there will be guideline reviews both internationally through the WHO and nationally. Certainly the Clinician Society are planning a review and would then go into guidelines, but there's still a lot of issues around cost of Ambizome, because even their access price is, you know, $16 a vial, and you need multiple vials depending on weight. So it's still quite costly, but I don't think prohibitively at an access price. But there's still quite a lot of work to do before it gets implemented.
Thanks, Graham. And that's a nice segue to lead to Nilesh and comments around differences between Western Cape and national, and what additional work we should do to try and understand that data better.
So, Marianne, the access program, the flucytosine access program, is really trying to ensure that people have access to the current WHO standard, which is a week of amphotericin B and flucytosine, then followed by fluconazole. And as I mentioned in the chat, I think that there may be an impact on mortality in the Western Cape that can be seen at the provincial level rather than the national level, because flucytosine access is universal in the Western Cape at present. The provincial department has arranged for every single facility in the province to have access to that WHO standard of care, whereas in every other province, flucytosine is only available at selected facilities, mostly urban hospitals, usually in most provinces, 1 or 2 hospitals, which tend to be hospitals that see many patients with cryptomeningitis. But when we look at the national data, only about 6% of people are accessing flucytosine in the induction regimen. So, you know, it's a drop in the ocean, and so that is probably why we're not seeing a mortality impact yet in our national data. With regard to the surveillance data, you know, there are obviously differences from province to province. The national data sort of smooths it all out. And so that's the average reduction in the incidence of cryptomeningitis. I also pointed out in the chat that we obviously, when we look at incidence rates, we obviously remove the recurrent cases of meningitis. But those are really important also, because those patients often are those who struggle the most. They are not adherent, even after a diagnosis of meningitis, to their antifungals and antiretrovirals. And so those patients need additional interventions probably. So I think it's important to also count those cases, which we haven't been doing.
Thanks, Nalesh. And I guess that also means we're underestimating the true burden of this disease if we're only looking at first episodes and the full burden of the disease. In terms of broadening flu cytosine access in other provinces, I don't know if you have a comment, or if Graham, if you want to comment on that?
Just to say that in order for flu cytosine to become nationally available and included in the standard treatment guideline, it needs to be registered. And so it's under review by SAHPRA currently. They've promised to fast track registration, but I'm not certain exactly when that will happen. And once that does happen, so the National EML Committee has already reviewed this, the effectiveness of this regimen, and they've looked at the cost. And so I think it's just the SAHPRA registration that's required for national access.
Okay, great. So we hope that SAHPRA can move quickly on that. I'm going to come back to Graham for a sort of second round of comments. Graham has to leave slightly before the end of the meeting, so hence going in that order back to him. Graham, over to you.
Yeah, just to pick up on some discussion in the chat about CD4 testing, and certainly, you know, there has obviously been a decline in CD4 testing from the data that Mariette showed overall. But what is striking is that the proportion with low CD4 counts has remained the same. So, you know, one interpretation of that is that there is still appropriate testing of people with advanced HIV happening. That, you know, in hospitals, at presentation to care, at return to care after interruption, and that the CD4 counts that are being dropped are the unnecessary ones at high CD4 counts. You know, that the patient's doing well on ARVs and they're no longer having CD4 counts testing. So I'm not sure that we, you know, it's possible that we're missing some people with low CD4 counts, but that data would suggest to me that we're getting more appropriate CD4 count testing done. And I think, you know, that many clinicians will do a CD4 count on return to care, and use that to direct, you know, CRAG testing. Well, it's done as a reflex in the lab if it's less than 100, and then also to direct prophylaxis with cotrimoxazole, which, you know, which are two interventions that will have a mortality benefit. But yeah, you know, that's my take on the CD4 issue. Yeah, and then just to, you know, expand on just the issue that I was mentioning earlier, I think, you know, there really are strategies in terms of public communication that we, you know, as a province, we could be taking on, you know, around encouraging people to return to care if they've interrupted, explaining to them what the consequences are, making sure that, you know, health services are welcoming when they return. I've had so many patients say to me, I don't want to return. You know, in the hospital, you say to them, you need to go back and start your ARVs. And they say, but when I go back, the clinic staff are going to shout at me. And I mean, I can't tell you how many times I've had that. And so, you know, the MSF, you know, they came up with this initiative of welcome back clinics. And I don't know how far, and it was a great idea, you know, asking healthcare workers to completely change their perspective on people returning to care, and rather than castigating them, welcoming them and congratulating them for returning. But I don't know how far that has penetrated within our general health services. And really to just normalize the fact that people interrupt. It's just normal behavior. Everybody does it. And that we just, when people return, that's a great sign that they're coming back to care, rather than being critical of them. And, you know, that's not what our healthcare workers do. And we should find ways of going out into the community, tracing people, better networks of community health workers, using the media. You know, one suggestion that I gave to the former DG of Health was that we should have an announcement on national radio every night about HIV. It remains a national emergency with 8 million people living with it. Reminding people to take their medication, to return to care if they've interrupted, reminding families to support people with HIV. It's almost as if we've reached the state now where we just take it for granted that people will start treatment and stay on treatment, and we can just let things take their course. There's no national sense of the gravity of the problem that still persists.
Thanks, Graham. That sounds, yeah, it's certainly like a great idea, and it does feel sort of crazy that anybody can, but we know it's true, that one could feel scared that one's healthcare provider is going to shout at one when one comes back to take your treatment. I always laugh and say, you know, if the physio says, have you been doing your back exercises? I say, of course I haven't. Don't be ridiculous, you know. So we should, when we ask someone, have they been taking their treatment, we should be expecting them to say, no, I forgot for the last 3 weeks. Not expecting that people are sort of robots and take their treatment. Nathan, can we come back to you for any additional comments that you might want to make? And then I'd like to go to our panelists for comments after that.
I think I would reinforce what Graham's saying by noting that the latest iteration of the HIV guidelines put out by WHO also incorporate good practice statements to encourage client-friendly services, because there is a growing realization that friendliness of services is key to ensuring better retention in care. And the other recommendation that came out recently, which was on tracing and re-engagement for those who have disengaged, what the published literature shows is it works. If tracing programs work, they around 50% of people who are successfully traced agree to come back to care. So the intervention in principle works, but for it to work in practice, we need to ensure sensitive ways of doing that reinforce everything that Graham has said about the social aspects of why people are challenged to remain in care in the long term. So it's not, so just as we have in recent years thought to an extent about how to retain people in care, and how to do that in a way that ensures that the services are more welcoming, so reducing the burden on clinic visits and so on if you're doing well on treatment. We need a similar effort to ensure that the focus on tracing and re-engagement is done in a client-friendly way and not in a way that is punitive and can just lead to worse outcomes and more money. Well, more money without better outcomes. That was what I wanted to add. Thanks.
Thanks, Nathan. That's great. So I'd like to go to our speakers first, and then just so that they can be a little bit prepared. Two people I would like to invite specifically to join the discussion are Jonathan Eurfraud, because I know he has spent a lot of time thinking about the sort of cyclical pattern of art, the person's journey on art, and also about making treatment simpler for people. And also to Brian Rice, who I know has also been involved in thinking around that cyclical journey. So if you can be prepared that you're going to get picked on, I don't want to use that word, but we're going to ask you for specific questions. So Nilesh, I see your video is on, so we'll come to you first for any additional comments, and then Mariette, and then go to Meg. And Meg, the one specific question I was interested to ask you is that you saw this very large difference between women and men, that men who interrupt tend to do very poorly, and women tend to not have as high a risk of death, but also that people who are pregnant are at high risk of interrupting. So I had two specific questions for you, Meg, around that data. The one is this all in the B+ era, which I assume it is. And of course, in the Western Cape, we actually never did option B. So that wouldn't necessarily apply. But I was thinking about whether there would be people who had gone on to art and then stopped intentionally. But thinking aloud, because this is the Western Cape, we didn't ever do option B, so that wouldn't apply. But the second is, to what extent is women interrupting treatment being driven through them having cyclical interactions with the health service through reproductive health services or antenatal care, and then ceasing treatment either intentionally or unintentionally when they feel that the need to take treatment is no longer present in order to protect their pregnancy. So that's a hard one for you, Meg, but you've got some time to think about it. But let's go to MeSH first.
Thanks, Marianne. I just wanted to revisit that point I made towards the end of my presentation about ending cryptococcal meningitis deaths. And so, a couple of months ago, we launched a strategic framework to complement, I guess, other global strategic frameworks around AIDS deaths. There's obviously a global end TB strategy, which focuses to some extent on advanced HIV and TB, but there was nothing for crypto. And so in that strategic framework, we outlined things that essential tools that would be required for countries and for public health programs to actually reduce crypto deaths. And obviously crypto is, I guess, is a marker of gaps in service delivery in an HIV program. So it was around access to essential medicines, essential diagnostics, and also crypto screening programs. And I pointed out towards the end of my presentation that many of these tools are already available in a province like the Western Cape. And so the question for me is, what needs to be done in the Western Cape where, so many resources have been expended into the HIV program and monitoring outcomes, what could be done to reduce deaths in the Western Cape? And one thing would be to consider these gaps in delivery of HIV care, and also think about people who are interrupting ART, and think about designing some sort of bespoke intervention for people with advanced HIV disease, in addition to all these basic tools which are already available. Thanks.
Thanks, Nilesh. And perhaps we can come back to our discussants at the end of this round and just ask for, can it be achieved? And in addition to what you've suggested, are there any other, and what has been put forward here, what would be the package to end cryptococcal deaths in the Western Cape? And can we monitor and see that it's happened? So Mariette, we'll go to you next, if you've got any additional comments.
I was just looking at the flucytosine data quickly, and over and above from what I showed on the slide, it seems that in 2020, more than half of the crypto patients were treated with flucytosine, more than half, and in 2020, about half. So there's definitely an increase in the use. And then when I was preparing for this, I was very interested in the repeat episodes of cryptococcal meningitis. So we can definitely look into that as well.
I mean, it seems like an update to the Western Cape cryptococcal meningitis analysis. If somebody isn't doing it already, might be in order to help us understand patterns of disease in our province and the impact of flucytosine. Meg, can we come to you?
Great, thanks, Marianne. Thank you for the questions. We did see a difference between men and women in the multivariate model, variable model, when we stratified by sex. We saw that the baseline hazards for most of the variables that were risks or predictors of mortality were higher in females as compared to males. And this might be largely due to behavioral factors or something that we didn't measure, such as opportunistic infections that don't form part of the model. In the model visualizations, I think we saw that men that have a combination of increased interruptions and deaths in earlier durations of art than females. And this may be, I don't know, there was a study from Zimbabwe by Sikazwe and also a study by Catherine Orrell and team that showed that men were less likely to re-engage in care in comparison to women. And that might have a bit to do with explaining this. And you also asked about the differences in pregnant women. So the table that I showed you of the baseline characteristics did show a higher proportion of women who are pregnant that interrupted treatment versus not interrupting treatment. And I believe that's highly noise in the data. In the Western Cape, when people fall pregnant, they do go to different services, the ANC services, and receive comprehensive care. But the data collected in those services aren't always digital and may not filter as readily to the PHDC as the ART data does. And I think that that's improved over time, but this data is from 2008 through 2020. So there might be some missing ART data from those women attending the ANC clinics. Because in the multivariate model, when we look at mortality, we do see that pregnancy is protective. And maybe just to say that I agree with everyone who has talked about not only the vulnerabilities and the chaotic, life that people are in and having to take chronic medication, but we do need to concentrate on trying to make the services more welcome, available after hours, less time spent in the clinic when people do have to go pick up drugs, and maybe the frequency being less for picking up drugs so that we can retain people in care. And as Nathan mentioned, we do need to really consider how to appropriately start tracing people and bringing them back into care. So thank you.
Thanks, Meg. Jonathan, can I ask you just for your comments in terms of being involved very, very much in services in the Western Cape, but I also know very interested in this cyclical pathway of care and in making treatment easier for people, if you have any comments.
Sure, and please excuse me if this doesn't work very well. Oh, it looks very weird. I'm using an unfamiliar set of tools today. So yeah, I guess I had two questions first, Marianne, and the one was a challenge to the people who have better statistical skills than I do, and that is, is it possible, the conversation that was going on around CD4s and whether we do the appropriate testing or not, and Graham was suggesting that we do, or at least there's a signal that we do, is there some statistical wizardry that we can do to dig at that question, to understand, can we see what we can't see? Are we missing, is there a way to somehow statistically work out that we are missing important CD4 testing, and that would help us to communicate to our clinicians, to sort of maybe to re-energize, to encourage testing? I don't know, that's a question for the stats geniuses here. And the other thing I just wanted to ask, Meg, I think you showed that quite a high proportion of the death that you were seeing was within the first 6 months after initiating treatment. Is that true? Is that also true in the first 6 months after reinitiating treatment? So basically, is it also true that when you reinitiate, a high proportion of the death is happening in those 6 months after reinitiating treatment?
So I'm wondering, Meg, if you can respond to Jonathan's second question, and then we can see if there are any statistical gurus who can give us a statistical answer to his first question. Although one of the questions I was thinking is, well, what is the optimal proportion with low CD4 that we should be aiming for? We aim for a certain proportion positive with TB testing, but what is the proportion with low CD4 we should be aiming for? Meg, can you answer Jonathan's second question?
Thanks, Marianne and Jonathan. Difficult question because I statistically haven't looked at it. Although I do think that people who interrupt, their CD4 counts do decline. And if those CD4 counts decline to less than 350, we do see that raises the risk for mortality in those first few months. So I would be inclined to say yes, but I would have to look more deeply at the data to be able to answer that. And other people on the call might be better placed to respond to that as well.
Thanks. I'm mindful of the time and that, Graham, you need to leave in a few minutes. So I'm wondering if you want to both talk about, is there an optimal proportion positive or proportion with a CD4 less than 200 that we should be trying to reach? And if you've got any innovative ways of how we could look at that, although I'm not asking you to be a statistician. And then also any closing remarks of, is it feasible for us to eliminate cryptococcal deaths in the Western Cape? And is there anything else? If you had a few, a set of wishes, what would they be to get us to no cryptococcal deaths?
Yeah, so just on the CD4 question, it's a really difficult one because there are going to obviously be temporal trends. And so, it's, as Jonathan said, how do you know what you're not seeing because of under measuring? And it's just, my impression is that, because it's remaining constant, you wouldn't expect it to have gone up, because if it was, we would then be seeing more HIV deaths, which we're not seeing. And so I think in a ballpark kind of way, we're probably not, missing more low CD4 counts than we were in previous years. That would be my, non-statistical perspective on it. But on the issue of cryptococcal, eliminating cryptococcal deaths, clearly all of the things that we've discussed in terms of ARV services and retaining people in care is going to be critical. But acknowledging that any intervention in that way is only going to have a partial effect, and there's still going to be people who cycle in and out of care or present for care late. Then, Nilesh and I have discussed this. There are gaps with respect to the CD4 goes off to the laboratory, the CRAG test comes up positive, and then there's a delay getting the patient back and getting them onto fluconazole. That's one area where the gap could be filled in to get people, as soon as the CRAG is positive, get them back for an assessment. Do they have meningitis symptoms? Yes. They, referred to hospital. No, they would, ideally get a lumbar puncture to exclude meningitis. Or if they're asymptomatic, started on fluconazole. So trying to reduce those time periods, which, people will progress to meningitis quite rapidly. And then there's kind of community awareness and healthcare worker awareness about the significance of a headache in people with HIV and the need to consider meningitis. And I think the presentation to hospital is often after a few weeks of a headache. Whereas actually, that should be a lot faster, and that would improve prognosis. So, I think there are those things, but it's both, addressing HIV, broad HIV issues, as well as addressing gaps and delays in CRAG screening, and then more rapidly making a diagnosis of meningitis when people are developing symptoms and early lumbar puncture and appropriate treatment. And then, finally, just a very broad comment. I just challenge everybody, to say, what are we going to do with this observational research that clearly identifies that there's a problem in terms of retention care and people with advanced HIV, despite the huge advances that have been made over almost 2 decades now in the Western Cape in terms of ARV provision. We still have this problem, and shouldn't we, as a province, and as people working in the health services, be trying to highlight the problem to policymakers and program managers in a more visible way, and saying, can we develop differentiated services, tailored services that tailored to that 10 to 20% of people that really have trouble with the current model of care, in terms of supporting them with community health worker going out, supporting people with adherence problems, finding accessing injectable treatment for those people who want it, trying to develop better tailored treatment services overall, but also specifically aimed at people with adherence problems, and that will save lives. So I think, clearly the observational epidemiology is important, but we need to also move to what interventions could follow it. Yeah.
Thanks, Graham, and thanks very much for your contribution. You would normally be part of the thank you at the end, but I'm going to thank you now, acknowledging you need to leave, and that's been really fantastic to have you as part of this discussion, and thanks for that challenge, which I think is really important and links to a question that Andrew actually put in the chat, and I'm trying to find it now. But related to our very first discussion of these MeSH meetings around sort of people being on ART and the number on ART in the province. So I've lost the comments in the chat. Yeah, a lower proportion on ART in the Western Cape in general. So Andrew was commenting that national surveillance shows declining numbers with cryptococcal meningitis, but in the Western Cape, we're not seeing this decline in cryptococcal disease. And is this possibly because our coverage is lower than in some other provinces? And we know that a big contribution to that coverage is people who we know about, but are not currently on treatment. So many thanks, Graham. I want to move to invite Brian, if he wants to make any comments on people cycling in and out of care and this longitudinal journey that our patients face.
Thanks, Marianne. I'd forgotten that I might be called out, so I've just quickly run and got out of my slobby jumper and put on a shirt. So I appreciate that. First of all, can I just say thank you on behalf of the London MeSH team for Nisha and her colleagues at University of Cape Town putting on this series, a fantastic convenience. I'm getting so much out of it personally. I'm sure many or more on the call, and for all of you giving over your time and expertise. We really do appreciate it, and we're looking forward to promoting this series of calls more via our website and our other engagements. Just quickly to touch on, before I get to your question, Marianne, on the CD4 thing, I'm going to come away from this call more optimistic based on the comments of real global experts in this field. I probably still remain a little bit pessimistic. We've done some landscaping and data-led exercises now through MeSH in Tanzania, Kenya, Malawi and South Africa, all which didn't paint the most optimistic picture about how CD4 was being conducted and utilized. And that was in clinical decision making, but particularly perhaps my pessimism came from its potential ongoing use in existing and future epidemiological responses that are based on CD4. And much of my career has been based on modeling CD4 count for population level surveillance, and their volume and frequency matters. And I know that obviously global guidance changes that volume and frequency, but come away optimistic, but still a little pessimistic on the surveillance side of things. In terms of the work itself, I'm not going to go into nitty-gritty because I have the privilege of being able to comment on people like Meg's analyses on a regular basis, which I do see as a privilege. It's fantastic work. But the MeSH Consortium, Andrew's team, so it's kind of Meg, Marinette, Alexa, Jonathan and Vanessa Timmerman, they're taking forward an analysis under the MeSH consortium. And it gets driven by this work that Peter Ehrenkratz, of which Andrew and Nathan were co-authors on. He published this paper, which kind of said the somewhat obvious, which is that our current cascade approach is very rigid. It oversimplifies as this complex cycle of engagement, disengagement, re-engagement. And so the Gates Foundation tasked us, and we had a conversation with Andrew, to start trying to populate this cyclical or dynamic cascade. And that's what some of the work you've seen today is coming from. And we actually had the privilege of Vanessa, I think it was, presenting to us about a week ago, where they've got new data views on your fantastic data at the Western Cape Province Data Centre. And they're starting to tease out this. It's not easy. One of the reasons that the cascade was constructed as it was is that it's quite easy to have singular time points. Once you start bringing in multiple time points, the data gets quite complex, doesn't it? But we're really looking forward to seeing those outputs and seeing the kind of the first fleshing out of that cascade. So thanks to all.
Thanks, Brian. And I think part of understanding that longitudinal patient journey is important as we think about how do we design services and how do we make it easier for people to stay in care, and where are they when we need to try and bring them back into care. Nathan, I'd like to ask if you'd like to make any closing remarks at this point, and then I will hand it over to Andrew to thank us and end the meeting.
Sure. So thank you very much, and I'll be brief. Thank you for the invitation. Thank you for putting together the session, and thank you for sharing all the data from the various presentations we've had. I think I want to end by again agreeing with Graham in saying that it's important to, as far as possible, move from observations to interventions. And what you are certainly doing a great job of contributing to is continuing to help us to understand the burden of advanced HIV disease. WHO has this public health approach, which includes a simplified package of interventions, which largely deal with a focus at tuberculosis and cryptococcal meningitis. And we have some ongoing work to continue to ask ourselves the question, how can we adapt and improve this package of care approach? And some areas we know need more work. One is, what can we do to respond to severe bacterial infections, which is an important cause of mortality among people with advanced HIV disease. We're having a consultation hopefully before the end of this year, but we're welcoming any data and insights that could help us to refine our approach. Another would be about who's at greatest risk. So targeting interventions programmatically with an understanding of which patient characteristics are more likely to be those in need of an advanced disease intervention. And should the package be adapted to certain population groups? So children obviously have a different disease risk profile when they have advanced HIV disease, and people who are treatment interrupters and re-engagers in care. Should we think about additional aspects of this package of care approach for those individuals? Obviously, social support, possibly reinforcing the need for a viral load at re-engagement in care, and it remains an open question whether there is anything else that needs to go into the package that is different from re-engagers compared to newly treatment naive individuals with advanced disease. So that's some of the questions we continue to have, and we continue to look at you all to help us find answers. Thank you very much again for this invitation.
Thanks very much, Nathan, and thanks for being part of the meeting. So I'm now going to hand over to Andrew to make some closing remarks and end the meeting. Andrew, I'm going to ask you 2 specific questions in the Western Cape in relation to NeSH telling us we've got all the tools to end cryptococcal meningitis deaths in our province, and some of the gaps of care that Graham highlighted. So my first question, and I should know the answer to this, but I don't, is do we have an alert for positive cryptococcal antigen tests? And should we have if we do have that, should we have another alert for people who don't appear to have been put onto treatment? So those are my 2 questions, the kind of technical quick wins that we could use. And the other is, and you may not know the answer to this, but perhaps some of the data that we've been looking at is how well are we doing at getting people onto dolutegravir in the province. And I know that COVID has not made it easy because people are not coming to care as often. And so the viral load less than 1,000 requirement is harder to meet and to switch. And maybe it's not a bad thing that we're not moving people onto dolutegravir, because maybe they're stable and doing very well on their efavirenz and they're happy to stay there, and we shouldn't mess with the good thing. But I don't know if you can comment on those 2 in particular as you close.
Thanks, Marianne, and thanks to everyone for this great session. But maybe before I close, Jackie, I see that you're on the call. Do you want to maybe just comment on the dolutegravir? You might have the best vantage point.
Hi, caught me a bit off guard, but from the data from the looking at CDU and JAC data of people on TEE and dolutegravir based regimens in the province, there's about just over 70% of patients on a dolutegravir based regimen, and the majority is on TLD of that 70%.
Great, thanks, Jackie. So that sounds like pretty good progress, and I know it's regularly reported on at provincial level and to PEPFAR, so it's definitely being aggressively tracked. In terms of quick wins, Marianne, I think it's all about capacity to respond. So no amount of tech is going to fix anything unless we've got the systems in place to be responsive. And those same, my sense is that those same systems, whether it's about identifying people who lost, re-engaging people, making services more friendly, making services more accessible, it all takes drive and commitment. I wonder whether this, we've got an emergency plan for TB that's been developed with some of the urgency or with the intention of some of the urgency that came out of COVID, and I wonder whether we don't need the same for HIV, or whether it should be an HIV-TB combined plan. TB deaths are the biggest cause of HIV mortality, and HIV is the biggest cause of TB mortality. So maybe we just need to tackle them jointly. I'm closing largely because Nisha had to leave early as well. So I wanted to thank Nisha in her absence and Marianne for excellent chairing, and to thank NeSH, Mariette, Meg for the presentations, and Graham and Nathan for really giving us a fantastic discussion, and for all the inputs. And then just to thank the participants for these 3. This is a bit of an experiment doing these seminars. We thought a space like this might be useful. If you have any feedback or suggestions for future seminars or formats that might be useful for this kind of thinking about routine data, then please let us know. We'll have a meeting in about a month from now as the MeSH team, just to review whether this has been useful or what other activities focused on routine data might be useful. And with that, thank you very much. And yeah, we'll post a link to the recording and to the historical recordings. And thanks everyone. Have a great weekend.
Many thanks all. Bye.
Thank you. Goodbye.
Thank you. Bye.